All right, welcome. Respiratory anatomy. These are four major regions. So you have the nasopharynx, so that's your nose, and also your mouth, all the way up to your pharynx, and then you have your larynx, and then you get into the lower respiratory tract, which is the trachea, and beneath that, the lungs. And so, in the upper respiratory tract, let's look at some of the features you need to know. So, um, you have your tonsils, which you have your palatine tonsil, so that's next to the soft palate of the close to your pharynx, and then you have your lingual tonsil. You have your hard palate over here, so that's the bone that forms the roof of your mouth, and the soft palate is the softer part end of that, which ends in your uvula. Your uvula is that little thing that you can touch at the back of your mouth and wants to make you throw up. And then demarcating the airways from the esophagus, there's the epiglottis right here, and sorry, I'm going back and forth here, but just go with me. Here at top is the concha. So the nasal a concha is pretty much a fold within the within the nasal chamber. That fold does three things. It will moisten air, it will clean air, and it will warm the air such that it's ready to go into the trachea and the lungs. And then once the air goes through the nasal cavity, it passes by the pharynx, and then it gets to the opening of the larynx, which is covered with the epiglottis. And so once the epiglottis is open, air can go in, whereas if it is closed, air really it's to prevent food from getting into the airway. And so here is a transverse section from a human plastinate. So you have the nasal concha, that's that fold over here, and here you have your vestibule. This is bone, so that's still the end of the hard palate. So that's a hard palate, and the end of it actually is a soft palate. So this is the larynx, and there's some things, that's the epiglottis, the hyoid bone, the laryngeal prominence, or your Adam's apple, and you have here your thyroid cartilage right there. And that's again it's the prominence of that thyroid cartilage that forms your Adam's apple. And then you have your cricoid cartilage underneath that. And here is the trachea. So what's shown here is the transverse section of the trachea. So it branches into two bronchi at the carina. The carina is the point where it branches. And so this image on the right here is a section of the trachea. So what you see here in purple, that's your pseudostratified ciliated epithelial cells, or the goblet cells. This was goblet cells, but these are the remaining epithelial cells. The cilia are the little finger-like projections that enable this epithelium to, in a consistent, rhythmic manner, keep flicking in such a way that it moves things from the trachea out. So that's that, and then you have your goblet cells right there, and they make mucus. So and then you have in the lungs, you have the bronchioles that branch off the bronchi, and the bronchioles ultimately branch off to terminal bronchioles, which lead to respiratory bronchioles, and that ends up in an alveolar duct, ultimately ending up in an alveolar sac. And the general anatomy of the system, so the upper respiratory tract, so that's from your mouth or nose all the way up to your to the entrance of your larynx right here, and then once you are in the larynx, all the way down to the lungs is your lower respiratory tract. This is the place where if you have an infection, it's called a pneumonia, and it's more it makes you more sick. Over here at the top, upper respiratory tract infections, those could be serious, but a lot of our respiratory infections that we see are upper respiratory infections. And then in terms of the anatomy, the functional organization, so most of it actually is just is a conducting zone. The goal here is to get the air that you breathe in to get to the alveolar sacs, which are really at the bottom of the chain. So this is an alveolus. So this here is one, and another one. Okay, and so that's the epithelium, type 1 epithelium. That's the flat cell, squamous cell. So which ensures that the epithelium is very, very thin to enable exchange of air, and through the alveolar cell membrane to the adjacent blood capillaries. So it's the lung tissue has a high density of blood vessels or capillaries, and so that's to exchange a to facilitate the rapid exchange of air. And then you have another type of cell called the alveolar cells. Those are much bigger cells, and they are the ones that make a surfactant which coats the alveolus and prevents their collapse. And you also could have macrophages within this to digest or to engulf any foreign material that makes it that far. And so the lungs, on the left side, there are only two lobes, and there's an oblique fissure. On the right lung, there are three lobes. And the reason is the heart is on the left lung, so it's in that area. So you have a superior and inferior lobe, and you have a middle lobe only in the right lung. Okay, so the process of inspiration and expiration, basically it is generating negative pressures or positive pressures within the thorax that makes air go out. But remember that increased volume, if you increase the volume and don't change the amount of matter in a enclosed space, then pressure will decrease. And so here is in the atmospheric pressure, typically around 760 millimeters of mercury. When I want to inspire, two things happen. The external intercostal muscles lift up the rib cage, and the diaphragm contracts, and together the width and the height of the thorax is increased. Because you've increased the volume, pressure will be lower, so the intra-alveolar pressure is 758 millimeters of mercury. And so that's what causes quiet inspiration. But if, on the other hand, you want to breathe like really deeply, intentionally, or because you need it to during exercise, then you would have to recruit other muscles, and those muscles are the scalenes, the sternocleidomastoid, and the pectoralis minor. And so that'll be forced respiration, inspiration. And then the expiration is at rest. It's just due to recoil of those muscles. The diaphragm recoils, the external intercostals recoil. That in its own causes the rib cage your thoracic volume to decrease, and ultimately with decreased volume, pressure would increase, and that's enough to move air out. Okay, but if I want to do forced expiration, the muscles involved will be your internal intercostals as well as your abdominal wall muscles, your rectus abdominis, and your abdominal obliques. And so here's what happens here. When you are breathing in, external intercostals will expand and will contract, and because of that, the space increases. That causes a decrease in pressure, so the intrapulmonary pressure is kind of -3, and that is enough to make air just naturally flow down its gradient from the external atmospheric pressure will push the air in. And when you breathe out, Now the thorax is a lot smaller and you have a positive intrapulmonary pressure, and that causes air to move out.